Buenas noches, nos encontramos reunidos hoy solamente en forma virtual a través de el Zoom de la academia y a los que nos escuchan por el canal de YouTube para empezar la sesión del 31 de mayo en este día. Les agradecemos la presencia y lo primero que tengo que comunicarles es que a propósito del acta de la sesión anterior, el doctor Alberto Ferreres va a hacer una contribución al trabajo presentado por la doctora Romina Bianchi y el doctor Leiro, cuestión del talento en salud en la República Argentina, análisis de la situación actual. Doctor Ferreres, si puede leer su comunicación.
Gracias, señor presidente. Bueno, en primer lugar, quiero hacer llegar mis más efusivas felicitaciones a los doctores Leiro y Bianchi por el trabajo leído en la academia el 17 del corriente. Amén de agradecer la remisión del trabajo original que realmente sorprende por su fundamentación y calidad. Los autores se abocan al análisis y evaluación de la gestión del talento en nuestra especialidad y en nuestro medio, y los resultados obtenidos e informados no hacen más que confirmar las presunciones existentes. Es interesante rastrear los orígenes y el desarrollo del concepto de talento humano, los que se remontan a la segunda mitad del siglo XIX a la luz de la Revolución Industrial, que Marx definió como la gran catástrofe. La sustitución del capital humano por máquina genera una organización basada en la división del trabajo y en la identificación de los factores de producción representados por la mano de obra y el nacimiento de la clase obrera. Esto provocó conflictos en la relación patrón-trabajador, ya que el clima laboral afectaba las condiciones de salud física y mental, y los factores de trabajo repercutían en la productividad. La combinación de todos estos factores mencionados dio lugar al surgimiento de las secretarías de bienestar, que podrían ser consideradas las primeras oficinas del talento humano. Dentro de la gestión del talento existen tres corrientes. La primera vinculada a la formación clásica, la segunda la de las relaciones humanas y la tercera vinculada a las ciencias administrativas, que indudablemente es a la que escriben los autores. Si bien McKinsey, la consultora McKinsey, tuvo que ver con la introducción del término gestión del talento, en realidad fue un trabajo publicado titulado War for Talent, cuyos autores fueron Chambers, Fowlon, Hansfield, Jones, Hanking y Michael Salcero, que fuera publicado en el McKinsey Quarterly en enero de 1998. Estas personas trabajaban, consultores de esta firma, trabajaban en las oficinas de New York, D.C., Toronto, Charlotte y Atlanta respectivamente. Es muy interesante ver la portada de ese artículo porque en tres cuadros, el primero, Great Company, el segundo, Great Job, y el tercero, Great Compensation, con una bolsa verde con el signo peso, donde indudablemente tiene que ver con el aumento en la remuneración para el talento. No obstante, un año antes, David Watkins, de la compañía Softcape, fue quien acuñó el término por primera vez, definiéndolo como el proceso que desarrolla e incorpora nuevos integrantes a la fuerza laboral y retiene un recurso humano existente. La primera gran diferencia es que en nuestro medio el talento no siempre es remunerado como en otros ámbitos. Sumergiéndonos ya en el tema del talento en cirugía, los autores plantean la diferencia entre ámbito público, estatal y privado. Y yo creo que hay que llamar la atención acerca de la proletarización del trabajo médico y fundamentalmente contrastarlo con las expectativas de los millennials y ni qué decir de los Z o de los centennials. No obstante, también debemos insistir desde nuestra academia en redefinir el rol de las autoridades y la utilidad de los lineamientos y políticas en salud. Un trabajo de Clavien y Deis, expresidente de Suiza, publicado en Nature 2015, hablaba de que a los tres aspectos básicos de asistencia, docencia e investigación había que agregar el liderazgo y la gestión. Y creo que el planteo de los autores indudablemente cae de maduro en el concepto de calidad de gestión que deben tener los líderes. Pero no obstante, en nuestro medio existe una falta de adecuación de los niveles regulatorios y ministeriales acerca de cuáles son las expectativas de la atención de salud para la población y las necesidades a cubrir. Y un ejemplo que aparece en la primera página de los diarios en esta época de bronquiolitis es el de la pediatría. Y seguramente ni los que están en ámbitos estatales ni privados están conformes con la práctica laboral. Si uno bucea en las páginas del Ministerio de Salud, figura un documento que seguramente los autores conocen, respecto a una nueva formulación del talento humano en salud, periodo 2021-2024, donde el mayor concepto y el mensaje es la inequidad en la distribución nacional del talento humano en calidad y cantidad. Pero poco ha hecho el ente central y en este caso sí me gustaría saber qué opinan los autores respecto a eso. Las diferencias entre nuestro país y otros medios, por ejemplo Estados Unidos, son abismales, donde se espera en el país del norte que a mayor estudio, mayor será el ingreso futuro. Y es interesante destacar la opinión de Gary Becker, graduado de la Universidad de Chicago, con una tesis llamativamente denominada Economía de la Discriminación Racial, quien sostiene que en el país del norte se invierte en educación para obtener mayores ganancias que lo invertido. Los autores también destacan la actividad académica con participación en asociaciones científicas, desarrollo de estudio de investigación y publicación de artículos. No necesariamente creo que estas actividades se reflejan en una mejor o mayor actividad asistencial o impactan en el bienestar de los enfermos. Un ejemplo que lo avala en principio sería la clínica Geisinger en el estado de Pensilvania, con un manejo muy particular de la escuela de medicina y del sistema de salud que cubre aproximadamente a más de 1.800.000 personas, en el cual no me voy a detener. En síntesis, coincidiendo con los autores, creo que aún queda mucho por hacer y si no lo hacemos pronto, el talento necesario en la cirugía y en la medicina migrará hacia otras áreas de las actividades profesionales con el indubitable costo para nuestros enfermos y la sociedad toda. Y quisiera cerrar este comentario con una glosa de los beneficios de Séneca en su libro sexto, que sirve de prólogo para el libro de Laín en el Tralgo, El médico y el enfermo, que dice algo así. ¿Por qué no se cumple con el médico con el simple salario? Porque el médico no nos obliga por el oficio que vende, sino por su benigna y familiar buena voluntad. ¿Por qué le debemos mucho a estos hombres? No porque lo que nos vendieron valga más de lo que les pagamos, sino porque hicieron algo por nosotros mismos. Y cerrando, reitero mis felicitaciones a los autores del trabajo, al doctor Leiro y a la doctora Bianchi. Muchas gracias, señor presidente.
Muchas gracias, doctor Ferreres, por su participación. Queda ahora el comentario sobre su aporte del doctor Fabio Leiro. Doctor Fabio Leiro.
Bueno, buenas noches. ¿Se escucha?
Perfecto.
Perfectamente.
Bueno, en primer lugar, agradezco profundamente al doctor Ferreres también su participación y su interés en este tema, que lo ha motivado a hacer un valioso comentario, pese a no haber podido estar el día que hemos presentado nuestro trabajo. Está claro que todas las presunciones que teníamos se confirmaron en esta encuesta, que fue una encuesta bastante sencilla, y fundamentalmente el hecho de que la gestión del talento digamos, realmente no es mucha la que se lleva adelante en nuestro medio, que es más en instituciones privadas que en públicas, que también hay un sesgo en las respuestas y que en general hubo y encontramos un poco o un escaso interés en el tema. Creemos que, yendo un poco a su pregunta, que la academia debe involucrarse en este tema de gestión del talento, y si bien hay algunas excepciones como la que el doctor Ferreres mencionó, donde la mayor producción académica no necesariamente, o una mayor gestión del talento y mayor producción académica no correlaciona con mayor calidad de atención, en general creemos que cuando los profesionales están más dedicados a la investigación, probablemente puedan obtenerse datos que ayuden, quizás no a mejorar en ese momento, pero a largo plazo llevar una mejor atención de los pacientes. Y por otro lado, creemos que el Estado tiene muy poca, en nuestro medio, tiene una muy poca regulación en el sentido de favorecer la gestión del talento. Por un lado, porque digamos, no está clara la alineación de incentivos, no se premia ni la productividad ni tampoco la capacitación. Y en realidad este tema es un tema que en el mundo empezó a tratarse más profusamente a través de las escuelas de negocios, porque claramente el talento asociaba a la mayor rentabilidad de las empresas. Pero bueno, esta experiencia también la podemos tomar desde la gestión en salud y aprovechar un poco todos estos conocimientos. Un punto que creo que es muy importante y en el que quizás se ha trabajado muy poco y se sigue trabajando muy poco, tanto en el ámbito, más quizás en el ámbito público que en el privado, es el tema de la retención del talento. La retención del talento o de los empleados más talentosos es algo que en el mundo de los negocios genera enormes pérdidas a las empresas, y también en el ámbito público, en salud, también se ve que el ámbito público destina muchos recursos a formar profesionales, y estos profesionales después, al no verse compensados, como mencionó el doctor Ferreres, terminan migrando hacia el sistema privado de salud. Y esto realmente es una inversión que se termina perdiendo. Bueno, no mucho más para comentar, es un tema que da para discutir largamente, y agradezco nuevamente a todas las personas o los académicos que participaron de la discusión 2 semanas atrás, y especialmente al doctor Ferreres por su interesante aporte esta noche. Nada más.
Muchas gracias, doctor Leiro, por su participación. Ahora vamos a escuchar a nuestro secretario general, que va a comunicar los asuntos centrados. Doctor Montesinos, tiene la palabra.
Buenas tardes, muchas gracias, doctor Matera. En razón de la muy baja concurrencia registrada en el Salón de la AMA durante las últimas sesiones, la Comisión Directiva ha decidido la suspensión de la modalidad presencial y continuar exclusivamente con la virtual. Quedará la presencialidad limitada a las ocasiones que lo ameriten. Los asistentes a las sesiones en este modo virtual pueden registrar su asistencia en el formulario del link que se copia en el chat en vivo, ya sea en las categorías de miembros de la academia o como no miembros, y también en el chat de Zoom para los miembros de la academia que se conecten por este medio. La asistencia al 50% de las sesiones del año anterior es uno de los requisitos para ingresar como miembro asociado o pasar de miembro asociado a miembro académico. Los asistentes a las sesiones que no sean miembros de la academia podrán seguir haciendo preguntas o comentarios por el chat de YouTube. A fin de cumplir con el objetivo de la academia, que es el estudio y difusión del progreso de la cirugía, su campo de acción, sus competencias específicas, la comisión directiva enfatiza la necesidad de que los miembros de la academia envíen comunicaciones, casos interactivos y videos científicos para integrar así las sábanas de las futuras sesiones. Recordamos que las presentaciones pueden no ser inéditas. Existe interés que los trabajos que sí sean inéditos y sean leídos en la academia sean enviados para su publicación a la revista Argentina de Cirugía. Los manuscritos deberán ser enviados por los autores a la Secretaría de la revista. La presentación deberá ajustarse a su reglamento, disponible en la página de la revista. Todos los trabajos serán enviados a revisión por pares de acuerdo con la política de calidad editorial. Llamado concurso, se llama concurso del 15 de mayo hasta el 2 de junio para optar a 5 cargos de miembro académico, 5 cargos de miembro asociado y 5 cargos de miembro correspondiente nacional. Las condiciones se encuentran en los artículos 3 y 4 del Estatuto. Trabajos a premio. Del 1 de mayo al 31 de julio se realiza la inscripción de trabajos para optar al premio Academia Argentina de Cirugía 2023. Los trabajos deberán ser inéditos, realizados en Argentina, y los autores no ser miembros de la Academia Argentina de Cirugía. Las condiciones están detalladas en el artículo 29 del Estatuto, que se encuentra también en la página de la Academia. En cumplimiento con lo autorizado por la última Asamblea Ordinaria Anual y con motivo del aumento del valor de los gastos corrientes, la Comisión Directiva ha dispuesto un incremento de la cuota mensual a 3.000 pesos. Se recuerda que el valor anterior no se modificó desde septiembre del año pasado. La Comisión Directiva ha aceptado la renuncia de los doctores Javier Carlos Lenduar y Oscar César Invertaza al cargo de miembros académicos. También fue dado de baja el doctor Octavio Gil. Lamentamos comunicar el fallecimiento ayer del doctor José Raúl Buroni, quien fuera destacado miembro de mérito de esta academia. Acompañamos a su familia, amigos y discípulos en este triste momento. Y por último, el miércoles próximo, 7 de junio, escucharemos la comunicación La diversidad de género en el liderazgo de las sociedades académicas y profesionales. Sus autores, Mariana Antelo, Cecilia Sforza, Mosetic, Pereira, Ortiz y Borkin. Y el doctor también Raúl Alberto Ferreres, quien será el relator de este trabajo. Nada más, muchas gracias.
Muchas gracias, doctor Montesinos. Y hoy vamos a escuchar una conferencia por invitación del doctor Douglas Brown, que va a hablar de futilidad en cirugía, y el doctor Alberto Ferreres, quien ha invitado al doctor Brown a participar de para brindar esta conferencia, va a hacer una introducción de los antecedentes y quién es el doctor Douglas Brown. Doctor Ferreres, por favor, gracias.
Gracias, presidente Matero. Douglas Brown es un nativo de Maryville, Kentucky. Se recibió como Bachelor in Arts, posteriormente Master in Divinity y obtuvo su PhD en la Universidad de Louisville, en Kentucky, en pensamiento medieval, con una posterior especialización en la Universidad de Oxford. Sus estudios postdoctorales fueron en la Universidad de Tennessee, en Memphis y en Michigan State, donde inició su vínculo con todo lo que tiene que ver con la ética en medicina. A partir del año 2007, se incorporó al Departamento de Cirugía de la Universidad de Washington en St. Louis y al Barnes Jewish Hospital, como consultor en ética y con una dedicación exclusiva a la ética en cirugía y a la enseñanza de pre- y posgrado de esta disciplina desde el año 2009. Cabe recordar que el Departamento de Cirugía de la Universidad de St. Louis estuvo a cargo de grandes espadas de la cirugía, con integrantes de FUSTE, como el doctor Tim Eberlein, que se acaba de retirar el año pasado y que sigue siendo el editor en jefe del Journal del American College, de Steve Strasberg, reconocido por todos los cirujanos, no solo los HPV, Bill Chapman, el trasplante hepático, Nat Soper en su momento, Michael Brand, Ira Connor, cirujano colorectal, Mary Klinkersmith, que actualmente es vicepresidenta del American Board of Surgery. O sea que la experiencia de Douglas Brown como PhD en el campo de la ética en cirugía ha sido fértil al lado de estas figuras seniegas. Actualmente es miembro integrante del CHES, que es el Center for Humanism and Ethics in Surgical Specialties, y también es uno de los líderes del Consorcio de Ética en Cirugía. Ha sido autor de múltiples libros. Yo he tenido el placer de tenerlo como autor invitado en uno de los últimos libros que hemos publicado sobre el tema de ética en cirugía, y estamos con un nuevo proyecto que es de una serie de casos y viñetas, 150 casos para enseñanza de la ética en cirugía, que está en proceso de elaboración. La charla que nos va a dar, como bien dijo el señor presidente, es sobre futilidad en cirugía. Y me gustaría hacer una pequeña introducción rescatando los conceptos de John Gregory, un médico producto del iluminismo escocés del siglo XVIII, quien fue el responsable de la transformación de la medicina de un comercio en una profesión. Él fue quien consignó que la medicina es una práctica moral y la tarea de los médicos es una tarea fiduciaria y moral. Definió a la medicina como el arte de preservar la salud, de prolongar la vida, de curar las enfermedades. Y meses antes de su muerte, acaecida en el año 1772, la de hacer la muerte más fácil. Muchas veces los médicos nos empeñamos en hacerla lo más difícil, lo más costosa y lo más dolorosa posible. Y a eso se refiere la charla que nos va a dar Doug Brown sobre futilidad en cirugía. Thanks so much, Douglas, for your lecture in advance.
Doctor, can you share your presentation, please?
Yes. So I trust that everyone can see the slides, correct?
Yes, okay.
Yes. And I hope that the audio works just as well. I deeply, deeply appreciate the opportunities today, this morning for Grand Rounds, and for this evening to address the Argentina Surgery Academy. It is quite an honor for me, and I wish to thank Dr. Ferreres and others for creating this invitation. We are, when I say we, I reference my wife and our youngest daughter, her husband, and their 2-year-old daughter, our fourth and youngest grandchild. We are in Argentina and Buenos Aires for the first time on this visit. We arrived last Saturday and have fallen in love with Buenos Aires. Our hotel is in the old part of the city. It's a boutique, small hotel in San Selmo. And on Saturday, we explored the immediate vicinity very thoroughly. We delighted in finding the nearby food court and have returned several times. On Sunday, we made our way to and I apologize for mispronouncing terms and geographic locations, but the Boca area where the football stadium is, not knowing what a unique experience awaited us as we became a part of the crowd for the football game on Sunday. And we brought back many memorable impressions of the enthusiasm of the fans surrounding the stadium. On Monday, we made our way to Tigray and spent the first part of the day there, and then took a boat taxi back into the Delta and paused at the Santa Rosa, I believe, village in the Delta, and had a delightful experience there as well. And then yesterday we devoted our time to the Palermo part of the city, and we have now tomorrow, Friday, Saturday, and part of Sunday before we return to the United States. It has simply been a marvelous experience, and we look forward to sharing those special moments with our close friends in the United States, and we look forward to an opportunity to return. I do want to apologize for my Spanish being so elementary that it's not possible for me to share these few minutes with you about surgical futility in your language, first language, primary language. And I appreciate your indulgence in working with a second or secondary language for these reflections. I certainly want to encourage you to take any idea, any slide, and Dr. Ferreres will have the set of slides to circulate to those who might be of interest, and make any construct, any concept your own, and translate or transpose the ideas into Spanish, and in doing so to recognize that when there are ethical conflicts and dilemmas surrounding the care for surgical patients, that the intensity, the passion, the tendency to struggle together with these complexities certainly needs the benefit of the most fluent and nuanced language. So please feel at liberty to make any transposition use of the ideas today into Spanish in order to take full advantage. I should say at the beginning that I have no disclosures that would indicate conflicts of interest that would compromise the discussion of the subject. And I would call your attention to the hint in the subtitle that I've adopted, hint of the orientation that I would take, and that is when a trial of treatment does not make sense. My experience has been more as a practicing ethics educator and a resource working and living in the midst of physicians and surgeons, nurses, social workers, and others who work every day together in the delivery of care to those who need help with injury or disease. It's been my privilege to work in many capacities in roles that make me a part of the hundreds and thousands who go in and out of clinics every day and hospitals every day professionally around the world. My earliest opportunities came with a faculty position with the OBGYN department at the University of Michigan, and then several years with a research team at the University of Miami that focused on cocaine abusing women who were delivering prematurely cocaine exposed babies. And I was a part of the field team making contact with these mothers who lived in very difficult and dangerous locations in Miami. I managed the obstetrics and gynecology residency in New Orleans for the University of Louisiana medical school, and then for a dozen years or so I was part of the leadership team for a primary care practice, including basic obstetrical care for a very rural and impoverished region of the Appalachian Mountains in East Tennessee. And I joined the surgery department in Barnes Jewish in St. Louis in 2007, and have had other roles at our medical school that have allowed me to be near enough the experience of the clinicians who are making decisions and are responsible for the care and the interest of surgical patients. And in doing so, I've tried to be an encourager and a ethics education resource. And I'd like to share with you this evening some of the collaborative observations and judgments that have resulted from this experience in relation to futility. I would mention that my earliest experience with this subject was as the spouse of my first wife, who was diagnosed with multiple sclerosis 2 years after we married. We married in 1971. She was diagnosed in 73. And she had an unremitting, deteriorating experience with multiple sclerosis for 14 years before she died at home in September of 1987. So running through my doctoral studies and into my first years when I was anticipating being a history professor, the experience of a spouse of a victim of chronic illness where there is no intervention was not then, still now, to correct the disease or recover from the disease. And it was through that experience that I was introduced to some physicians at the University of Tennessee in Memphis, where we lived at the time, who began to invite me to be this sort of anthropology / ethics presence in medical education and medical practice, and that's been the good fortune of my career for the last 40 years. I'd like for us to focus on a case as the anchor for the discussion this evening. And this is a case that was relayed by one of our surgery clerkship students at Washington University in St. Louis. These are the words of the clerkship student. This case still haunts me weeks later. This case was submitted about 4 years ago. An older lady was getting a G-tube and trach. She had suffered a very large stroke and had pretty much no brain function left, not enough to breathe and eat on her own, to speak or to communicate or to even be conscious. While we were in the OR, the team had a discussion about why this surgery was being done. Apparently, the patient's son had initially requested comfort care rather than aggressive attempts at restorative care. Then the son felt so racked with guilt that he did a complete 180-degree turn and asked for the team to do everything to keep her alive. The whole OR team bemoaned how awful it was that this was happening to this patient while doing the surgery that allowed it to happen. The student said, "I realize this is a very common experience, but it was an awful experience for me as a medical student, especially since I am planning to go into neurology. I now realize I will be dealing with these cases on a regular basis." I've attempted to probe respectfully this burden reflected by the student, and I'd like to share some of the results. For instance, I spoke with 2 surgery clerkship students who were near the end of a month-long ICU rotation, and I asked them separately, at any given time, how many of the management plans for the ICU students make no sense, no medical sense. The question I asked had to do with the link between the management plans and feasible outcome or discharge expectations. I would certainly be interested in your guess about how they responded. They each responded separately and independently. 50% of the cases that they experienced in the medical and surgical ICU made no medical sense. I've asked groups of residents at our medical school over the last several years some survey questionnaire statements to get their reaction, and I'll share a few of these. For instance, telling a patient no is paternalism. How would you react? Here is the way that our residents reacted in emergency medicine, OBGYN, general surgery. Virtual 100% of our residents said telling a patient no, they disagreed that that was paternalism. At the same time, when I asked them this question, physicians or surgeons are obligated to start management plans that are not coherent and do not make medical sense. How did they respond? 1 out of 4 agreed that they are obligated to start such management plans, even though they do not make medical sense. And when I posed this situation where you have a patient with decisional capacity who pleads, please perform any surgical option, however experimental, would they do so? More than 50%, close to 55% said they would, even though the questions surrounding experimental interventions are significant and complicated when it comes to the best interest of the patient. And I'll draw your attention to the question on the right, or the statement. I ask them to respond to this statement. It is a medical failure when a seriously ill patient dies without a sense of dignity. And notice that 3 out of 4 of those residents in our medical school who responded to this statement agreed that it was a medical failure, a failure on their part and their colleagues' part when a seriously ill patient dies without a sense of dignity. It seems to me that there are some practical ways that we can give a basic definition or description of futility. When we talk about a patient not being a candidate for a particular intervention, it might be dialysis, it might be a transplant, or other specific surgical interventions. When we say this patient is not a candidate for, we are implicitly saying it would be futile to do so, to engage in this intervention. I think we're talking about futility when we recognize that a trial of treatment has failed, is no longer compelling to continue this trial, this treatment modality. We are talking about futility. I even think it's useful as a reminder to notice that futility, even though it's not etymologically rooted, you remove the F, failure, off of the word and you end up with utility. And I think futility is when the intervention would receive a grade, an evaluation of F when it comes to utility. The type of cases that we find to be the most complicated in regard to futility are the 2 quadrants on the right of this diagram. The upper quadrant is where we find cases with high potential benefit, but also very high potential risk and burden. And so we strain to determine when that ratio tilts over and is weighted for risk and burden over benefit. But at the most complicated cases often are in the lower right quadrant, where we see no benefit, the benefit is extremely low, the potential risk significantly high, and yet we are being pressed by our own criteria for success, or by the patient's appeals or the family's appeals to do that which does not or no longer makes medical sense. I want to remind us that at least in the United States, we distinguish 2 types of futility. One is described as physiologic futility. And this type of futility has to do with the patient having no chance of recovery. Therefore, interventions are only prolonging the dying process. And then there is the often more difficult to manage value-based futility. This is when a patient's stated goals or expectations are not achievable. We are reminded that in value-based futility, we might have 2 patients who have very similar diagnoses, but one in the same intervention would be futile for one and not futile for the other. And the reason has to do with differing goals or expectations. I've noticed in many years of being on rounds with our surgery teams that there is a distinction that needs to be appreciated between futility at a systems level or a problem management level, a part of the plan for the day on routine daily rounds. There may be a futility in a particular intervention, but then there is the macro or integrated management plan, the big picture, if you will, and that's where you have a comprehensive assessment of the patient's condition or circumstance, and even though progress or favorable reaction to a specific system or specific problem might occur, that is overridden by the overall assessment that the patient is no longer making progress. And so the distinction between these two sometimes creates this confusion, because patients and families may hear us talk about favorable lab responses that are system or problem level and hear that as saying, well, the patient is getting better, when that is not necessarily the case. And then I'd like to remind you that in a teaching hospital, the patient-centered interest might lead to the conclusion that an intervention is futile, no longer makes sense. However, it may create an educational opportunity. I remember spending hours in our emergency department several years ago, when our emergency team and our surgical team both came to respond to a teenager who had been a victim of gun shots, several, and he was on the table and they were going through their protocols, and they continued past the point that they would have otherwise called for the time of death, because it created an opportunity for the two teams to finish their protocols and test their ability to communicate together. And so they continued their interventions past the point of a possible determination of death for education or training purposes. And the same thing often happens at our medical school, when the benefit or the opportunity might be for a research protocol, even though the intervention is no longer beneficial for the patient himself or herself. So a quick reminder about many ways to talk about ethics. This is the way we define ethics in our department. Ethics has to do with the determination of what ought to be done, all things considered. And we often find the origin of conflict about what ought to be done when we listen to each other for identifying what we are considering or what differing weight we are giving to similar considerations. So if this is the sort of landmark construct for how we try to meet our ethical as well as clinical responsibilities for patients around the question, what do we invite patients and families to trust? And that is that we will be careful not to harm them more and to deliver a benefit and respect the patient's perspective and expectations, and to be good stewards of limited resources and avoid bias against vulnerable population groups. This is what we hope for. We hope that we have sufficient medical facts, sufficient personal information and family information, and a decisional patient, or at least someone who can represent a patient who's not decisional, so that we can give a accurate, thoughtful diagnosis and prognosis and come up with a management plan that we can deliver because we have those resources and the goals are feasible and there is a discharge plan. This is when patient care goes well. This is where futility hits. When we find ourselves wondering, why do we keep doing this? When we find ourselves wondering why we keep caring in the attempt to restore a patient. Why do we end up appearing to torture patients in the way in which we keep aggressively intervention? The futility cases that are most burdensome are those that haunt us, that we keep thinking about. Lorraine Hill, about a dozen years ago at our medical school, at the time was a CT ICU intensivist. She and Jonathan Green, who was a medicine ICU intensivist, Lorraine is now at Columbia in New York, and Jonathan is now with the NIH. But the three of us tried to study this in our ICUs, and we identified 4 weaknesses that lead to these cases where the interventions no longer make sense. How do we end up in these cases? One vulnerability we found had to do with inadequate, incomplete information about the patient's condition. A second, flawed decision-making process. Too many people involved, not the right people involved. Third, vulnerability, the goals or expectations of the surgical team or very often of the patient or the patient's family. We have to have feasible goals that are explicitly documented. And then we have a number of patients who simply don't know how to understand scientific or evidence-based medical information. And so there is confusion or even resistance to such conversation that creates a barrier to care. So what I'd like to share with you are 4 tools, sort of takeaways that I would suggest that you pause to assess your own resources and maybe consider these as additions if they're not already represented. The first tool that I would recommend is that you have a set of peer-reviewed guidelines. I will share with Dr. Ferreres the set of guidelines for withholding or withdrawing life-sustaining treatments and a separate set of guidelines for dealing with code status issues that we have developed at our medical school over the last dozen years or so. These guidelines for withholding or withdrawing life-sustaining treatment have 4 sections. Section 1, key core terms that are clearly, succinctly defined. Section 2, landmark concepts related to withholding or withdrawing life-sustaining treatments are explained. Section 3, the process and the protocols are delineated so that we know how to actually take steps forward in decisions about withholding or withdrawing care. And then section 4, for us, we have a section where specific questions that physicians, surgeons, and nurses have asked, we give response to in the guidelines. The value of these guidelines for us is that it supports and encourages consistency across the care of a number of patients with the rotating of the team members involved in their care. So tool number 1, and I think very important resource to have, would be a set of guidelines that can provide that consistency. Tool number 2 that we've found very valuable is a documentation template that focuses on goals of care. And I'm not going to read through the specifics, but again, this slide set will be available to you, and that includes this template that we have created and modified over a number of years. But the thrust of this documentation template is to give some structure and orientation to the communication with the surgical patient or the surgical patient's surrogate and family about the goals and the expectations. What we're trying to clarify and document and share across transitions in the care team would be information about the outcome, the quality of life, both what is desired and what would not be desired as a consequence of this kind of aggressive intervention. And so the endpoint is to be able to indicate in the documentation the focus of care. Is there an understanding of goals and expectations that justify continued aggressive intervention? Or should the focus of care more appropriately be on the patient's comfort through the dying process? So tool number 2 is to have a documentation template to capture this information. I think we have, in our setting, in our hospital and department anyway, we have much more familiarity and ease of answer on the left side of this threshold. What constitutes a good outcome when our efforts are to restore, to cure, to correct an injury, to fight death? We need similar clarity and fluency when we're on the right side of this threshold. What is a good outcome when the focus is on comfort and dignity and managing the dying, and in a sense, being in league with death? Ideally, we will eventually, in a timely way, be all beyond the same side of the threshold and have that consistency or consensus for directing the care of the patient. Tool number 3 is a respectful, productive response to just do everything appeals from patients and patients' families or surrogates. I won't take the time tonight to go through this scenario, but I will simply point you to it and encourage you to read it, because this scenario describes what we often reach, and that is the point where the patient or the patient's family and surrogate say, well, doctor, I want you to do everything. This third tool is, for us, very, very important, because we don't want to get into a tug of war with a patient. We don't want to say, no, we're not going to do everything. That shuts down communication. What we opt for is to say, we will do everything, but we go on to qualify that. Everything that is medically reasonable, everything that is in the patient's interest, everything that's consistent with the patient's values. And you can see down this list how we are trying to affirm that we are still caring for the patient, but that we do so within certain parameters. And we're trying to clarify that. And so the slides share with you an alternative scenario to illustrate how this communication can go with patients or patients' families, so that we don't feel trapped or cornered by this appeal, just do everything. And then I would like to close my comments tonight with one more tool number 4, and that is a protocol that ends with a resolution for intractable conflicts. These are cases where we have we not only have reached a point of judgment, medical judgment about futility, but we cannot move forward in collaboration or partnership with the patient or the patient's families. And instead of going through every one of these steps, again, because of time tonight, I simply will point you to a 7-step protocol that we have adopted that results in step 6 with a timed opportunity for patients or patients' families to find a transfer arrangement to another hospital or another surgical care. At the end of which, if that transfer is not possible, then we will follow the medical judgment of our team. And step number 7 represents the involvement of the chief medical officer and other senior supervising members of the surgical team, so that we do not have this plan, this management plan moving forward, to break down when the service turns over. So these are the 4 tools that we have developed in our surgery department that stand out to me as providing a way to move forward in cases where futility has been reached, but consensus has not been achieved as to how to continue to respond in a respectful, caring way for the patient and still continue to practice what makes medical sense. So I'll stop there. I appreciate the opportunity to share with you some of the practical side of dealing with futility. And I would be happy after tonight to respond by email or any other communication means to any question or follow-up that you might have. I don't know if we have time for questions tonight, but thank you very much for this opportunity.
Thank you, Dr. Douglas, for your conference. We have time to listen for the questions of the audience. Have to you. Doctor Montesinos, ¿hay preguntas en el Zoom?
No por ahora. Acá el doctor Sunjo Young.
Bueno.
El doctor Sunjo Young ha levantado la mano.
Pues el doctor abrir el micrófono. Gracias, doctor Sunjo. Sus preguntas, sus comentarios.
Good evening, Dr. Brown. Thank you very much for your excellent conference.
Thank you.
Very descriptive and also comprehensive on a topic that is a matter of concern for every physician and also surgeon on a daily basis. I think there might be 2 scenarios where an ethical issue may appear. One would be the one in which there is time for a doctor to present the case to an ethical committee, for instance, when one cannot solve the situation oneself on his or her own, with his, her, or her own tools. So this would give an opportunity to present this case, and I think this is the ideal scenario in which each one of us can find support and counseling on how to manage these very extreme situations. But there is also another scenario, I think, the emergency one, in which usually we have, in surgery at least, we usually have younger doctors, less experienced ones, being on call, for instance, and having to decide this kind of situations. So my question would be, at your center, do you have any sort of a hotline where to which one can call anytime, 7/24, to present these cases and have support from the ethical committee? Or would you say this should be recommendable? Thank you very much again for your conference and your answer.
Yes. And I appreciate very much the question. I have been a member of, often a chair for hospital ethics committees for the last 40 years here in the United States. And my recommendation has always been that for an ethics resource, an ethics consult service to be beneficial, it needs to be timely, just like any other consult. And so if time permits, a response to an ethics consult within 24 hours, I think, is adequate to have a full, robust ethics consult response. But as you said, there are many cases that are more urgent than that. And so my recommendation, and our hospital and our department, specifically our surgery department, we are looking for ways to be more immediately responsive within, say, even in a few minutes. Obviously, the shorter the amount of time, the less multidisciplinary and the less reflective the ethics consult response is going to be. And so there is a give and take. And I think 24/7 availability, we should not use the word consult if we say it's only available 10 to 4, Monday to Friday. The hardest decisions often don't fall within those hours. And then what we are trying to do in our department, anyway, our surgery department, is to raise the skill level within our faculty and our fellows and our residents as far as being able to handle these ethically complicated situations. What we also have developed is a formal fellowship in which our faculty or our residents can go through a 1-year structured program of study to strengthen the ability to handle these cases. So I think more education is proactive and useful. I recently had a case in which we had to work our way through an algorithm, a descending algorithm, because of the very restrictions that you're describing. And it seems to me very important that even what we want to avoid, if we can, is one surgeon making withholding, withdrawing, life-affecting, existence-affecting decisions alone and unilaterally. That is the worst situation in which to be. And our approach is, if one of our physicians or surgeons finds himself or herself in that situation or in the favor of life. But we are doing everything we can to avoid that loneliness and isolation with these decisions. And so we are looking for ways to make a network accessible so that that surgeon at the odd early morning hour facing this situation has the knowledge and liberty of who he can call or she. It might be a colleague, it might be myself, it might be Dr. Kopar. The two of us directed this surgical ethics fellowship. It just, who are the individuals immediately that you can call that you will not have to spend a long time explaining, because they will have basic understanding of the surgical circumstances when you're pressed for time. And we're trying to keep any of our faculty, junior residents, from being alone in the decision. And the department is where I think that has to happen. The ethics committee of the hospital is more removed. And so we're trying to fill that void in our department in those ways. And I don't know if this is giving you an image of what we do, and I'd be happy to try to describe it in a paragraph a little bit more succinctly, but we are trying to avoid the faculty, junior, fellow, resident from being alone facing this situation. It's important to be able to articulate to someone our reasoning if we're making decisions about withholding or withdrawing.
Thank you.
Mm-hmm.
Thank you, Dr. Brown. Another question from la doctora Rosina Pache. She's a bioethics consultant in several institutions in our country, and she was studied in Spain, especially this area. Rosa? Doctora
Good
Pache,
evening, Dr. Brown. Thank you, Dr. Matera. Thank you for your conference, Dr. Brown. Maybe make me work more in this area. I like to ask you about the other side of this theme, that is do you use the direct, oh, sorry for my English, advanced directives from patients?
Yes. Did you say advanced directives? Is that the question?
Yes, because it's other element who is values in this theme. The negative of patient, or is other tools, probably.
Yes. And 2 or 3 thoughts come to mind in this regard. The living will, do you have living will as a tool? We have had living will option in the U.S. for more than 30 years now, since the early 1990s. When my wife, my first wife, was deteriorating, and the disease was compromising her clarity of thought in a rotating way, we decided to make sure we had a last conversation when she was clear, and we spent an entire afternoon on the back porch doing what later would be called a living will, in part, looking back, setting goals, addressing possible future decisions when she would not be likely able to have input. And so I think those, the living will can be helpful. The limitation we have found with a living will is that often the living will is filled out without physician guidance or physician availability to answer questions. So too often the living wills that are completed themselves don't make good medical sense because they're filled out by individuals without medical knowledge or understanding. The template, the goals of care documentation template, is an attempt to get more recent insight to put alongside a living will if a patient has a living will. We tend to put more value as helpful on a durable power of attorney for healthcare when the patient has designated someone to represent the patient when the patient cannot do so. The challenge there, ethically, has to do with the availability of the surrogate, the willingness of the surrogate, the decisional capacity of the surrogate, and the potential conflicts of interest for the surrogate. So once there might be identified a surrogate, we still ethically need to assess the ability of that person designated. But yes, those are the two advanced directives that are well established in the United States. We tend, I think, most often to prefer the durable power of attorney for healthcare because of the limited value that we tend to find in the living will information.
Thank you.
Mm-hmm.
Muchas gracias, doctor Douglas Brown.
Thank you.
Manuel Montesino, doctor Manuel Montesino, ¿tenemos alguna otro participante en el Zoom que quiera? Al doctor Marcelo Piari.
Thank you, Dr. Matera. Dr. Brown, thank you very much for the very comprehensive and clear conference. The person present here, we are all surgeons, but also medical educators with our residents and students. You have already introduced the possibility for your professionals to perform this 1.5 year intensive training in order to deep a little bit like knowledge in futility and topics related to the end of life. But how do you manage to do that in the undergraduate students? In the medical and nursing curriculum, how do you prepare your educators and your teachers in order to use, for example, simulated scenarios or simulated situations in order to let them, before being a resident, to be in contact with these clinical situations?
Yes. I will make sure that Dr. Ferreres has a fresh, updated copy of 6 promptings that I've prepared and in a collaborative way with several of our surgical faculty. 6, we call them promptings. They're short, like 1 to 2 pages. But because they are short, they are accessible. We're trying to put something in the hand of our medical students, of our nurses, of our residents, knowing that they often don't have large blocks of free time, undesignated time. And so we're using these promptings and circulating them one at a time. There are 6 that at least give some footing, some basic grounding within which to build one's fluency. And I will certainly make sure that you have access to those promptings. We also are looking for ways to, we ask for, like a few minutes, 5 minutes in a monthly or weekly nursing team meeting in the cardiothoracic ICU. If we could have just 5 minutes from time to time in the agenda of that meeting to have a ethics pause and take one question, one idea, and introduce it for discussion. In our department, we are adapting our morbidity and mortality conference to draw more attention to the cases that include morbidity or mortality, in which there were ethical complexities related to end of life and futility. So we're looking, we're not asking always for one more conference, one, adding, but finding ways to adapt the meetings and discussions that already exist as a way to be more proactive with our nurses and our case managers. Case managers are very valuable, as well as our students and residents and faculty. But I will get those promptings to you through Alberto.
Alberto, thank you very much.
I would very much welcome your feedback. And this is an illustration. If you think these promptings have any value as a rough draft, feel free to modify them, adapt them, and translate them into Spanish and make them your own.
Thank you, Dr. Brown. We will do, Dr. Rosina Pache and myself, we were together in our medical school. So we will take a deep look to your documents and send you our feedback. Thank you very much.
And any use you can make would be very, very pleasing for me.
Thank you.
A pleasing thought.
Thank you.
Gracias, doctor Figari, gracias, doctor Brown. Creo que en el Zoom no tenemos ninguna pregunta más. Doctor Lenz, ¿hay en el canal de YouTube alguna pregunta para el doctor Douglas Brown?
No, doctor Matera, no veo preguntas.
Sí, me parece hay una pregunta. Excuse me. Yes. Dr. Padim asked, how do you manage ethic faults among colleagues?
Manage, say that again.
Ethic faults, ethic problems among colleagues, among physicians.
Unethical behavior. Or okay. Unethical management or practice. Yeah. What we do in our department, I would say, is to seek additional information when we get feedback from students or residents, as far as individuals more senior to them, or colleagues who give feedback. The first question is still a hopeful question, and that is, here is the perception that has been reported to us, that has come to us. It might be a division chief who gets the information. It might be our team with our surgical ethics center in our department or whatever. But here is what has come to us now. What do we not yet know? Help us understand this. This is the way it looks. And it doesn't look defensible. There's a reason a question has been raised. What do we not understand? And we want to remain open to the possibility that there is additional information once it is gained that will explain the situation in a satisfactory way. So that's our initial step, to ask, what do we not understand in a non-aggressive way? If we seek additional information and it confirms the concern, then there will be disciplinary action. It will go up through the supervisors. If it doesn't involve the supervisors, it'll go through it'll eventually go to our vice chair for education. If it involves indefensible behavior in the supervision of students or residents, or it would go to our chair if it involves other types of unethical behavior. We have had faculty members dismissed from their appointment in our department. There is a due process, and we try to be mindful of that. But our responsibility in our surgery department is to protect the interest of our staff and of our learners and trainees and of our patients. We had a question to arise about possible cheating on exams related to surgery, the formal series of exams. What you have to check that. If you can't trust your colleagues, the whole edifice collapses. It's based on trust and confidence, in our colleagues. And if it involves students or residents in that regard, then we have to pursue it. We cannot cover it up. And I personally feel that our department, at least the situations I've known, the department has taken this seriously, and it has led on occasion to faculty members being dismissed from the department and the medical school.
Thank you so much.
Thank you, Dr. Douglas-Brown. Thank you. There are no any questions, and
no more questions. No more questions.
And we are close to the time to finish. Thank you, Dr. Brown, for your conference, for participating in our meeting every week here, and thank you very much. Muchas gracias, Dr. Alberto Ferreres, por haber traído tan distinguida y científico para esta charla que hemos tenido, y muchas gracias. Los invito a todos a participar el próximo 7 de junio de la conferencia que ya para dar de la presentación, la comunicación del doctor Ferreres, que ya el doctor Manuel Montesinos presentó. Muchas gracias a todos y damos por finalizada la sesión.